We move on to the next.
Yes, sir.
Yes,
So
sir.
myself presenting, sir.
Okay, go ahead, ma'am.
Renal replacement therapy, sir. My topic is indications of renal replacement therapy. Renal indications: uremic encephalopathy, uremic pericarditis, and uremic hemorrhage, and any fluid overload, metabolic acidosis due to renal failure, and hyperkalemia. Non-renal indications are any toxins or any drugs like alcohol, lithium poisoning, salicylate poisoning, valproate poisoning, and theophylline poisoning. Serum sodium more than 160 millimole per liter, or temperature controlled hyperthermia, and any sepsis, removal of inflammatory proteins. Types of renal replacement therapies are intermittent hemodialysis and peritoneal dialysis, renal transplantation, and continuous renal replacement therapy. Mechanism of solute removal. In continuous renal replacement therapy, there are types are continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, continuous veno-venous hemodiafiltration, and slow continuous ultrafiltration. Mechanism of solute removal. Hemofiltration. Blood is pumped through the extracorporeal membrane. Due to positive hydrostatic pressure is created, and it is filtered across the filter. Ultrafiltration. Due to convection, filtered fluid is discarded and replacement fluid is added to decide fluid balance. In hemodialysis, blood is pumped through the extracorporeal membrane, that is dialyzer. Blood is separated from the dialysate by semi-permeable membrane. It adds solids moves across the membrane of along the concentration gradient from one compartment to the other compartment. It obeys fixed law of diffusion. Hemodiafiltration, both combination of filtration and dialysis. Slow continuous ultrafiltrations are only water removal, and the minimal solid removal is minimal. It can remove up to 6 liters per day. Hemodialysis vascular access. Locations are commonly we are using AV fistula at a risk between radial artery and cephalic vein. And second one is AV fistula between brachial artery and cephalic vein at elbow. Third is AV fistula created using polytetrafluorourethane graft, sir. And central vein placement. Either double lumen tube, double lumen catheter in either right IJV or left IJV, or right subclavian vein and right femoral vein. Each one has advantages and disadvantages, sir. We have to allow to mature 21 days, and after that 21 days, the veins will autolysis of vein will occur, and veins are more prominent and bulging. Thrill will occur because of the high pressure system. Duration of treatment. Intermittent hemodialysis. It involves dialysing with higher flow rates. Typical regimens are typical regimen thrice a weekly, or it will undergo 3 to 5 hours. Only suitable for patients who are hemodynamically stable. Continuous renal replacement therapy involves filtering, dialysing in a continuous manner. It allows better fluid management and less hemodynamic stability, and requires continuous anticoagulation. Continuous RRT is suitable in sepsis patient, serious hemodynamic instability, and head injury. Which form of renal replacement therapy should be used? No single RRT technique is benefit for survival. So the decision is depend on the what we want to remove from the plasma. Is the patient cardiovascular status is stable or not? Availability of sources, experience of staff, other specific clinical considerations like any sepsis, head injury, or serious instability. Anticoagulation. All modes of renal replacement therapy will activate coagulation pathway to produce anticoagulation. There is non-pharmacological method and pharmacological method. Pharmacological methods are unfractionated heparin and low molecular weight heparin. Unfractionated heparin most commonly using, sir. Typical regimen is 40 to 70 units per kg, bolus followed by infusion at 5 to 10 units per kg per hour. It is the most cost-effective anticoagulant and fully reversible with protamine. Low molecular weight heparin is dependent on renal excretion. So low molecular weight heparin also has a longer half-life than unfractionated heparin. Prostaglandins, it can given alone or either with heparin, sir. Prostacyclins and prostaglandins E2. It inhibits the platelet function. It has a short half-life, sir. Side effects are vasodilation. It inhibits hypoxia pulmonary vasoconstriction, it leading to hypoxemia. Regional citrate anticoagulation, when the increase the bleed, when the risk of increasing bleeding, it is alternative to heparin also. So sodium citrate is infused into the circuit, and it chelates the calcium. So we have to supplement calcium also, sir, post filter. Pharmacokinetics and renal replacement therapy. Factors affecting pharmacokinetics are depends on protein binding. It depends on size of the drug and molecules, timing of renal replacement therapy, and dose of renal replacement therapy, membrane permeability. Prescription of renal replacement, it should be anticoagulant, how much units followed by infusion, and fluid balance over 24 hours, and types, what types we used for renal replacement therapy, and exchange rate and treatment dose. Complications, hemodynamic instability, any air emboli, blood loss, patient platelet consumption, electrolyte imbalance, hypothermia, and effects of anticoagulation like heparin-induced thrombocytopenia, sir. That's all, sir. Thank you, sir.
Okay. What about the peritoneal dialysis?
Peritoneal dialysis, it is acute treatment only, sir. We are using any emergency
No,
condition.
the question is renal replacement therapy. That is the way the question is asked. Peritoneal dialysis is also a mode of renal replacement therapy.
Yes, sir.
Whether it is for acute or whether it is chronic, doesn't matter. People who are not suitable for hemodialysis, they survive on ambulatory peritoneal dialysis. Continuous ambulatory peritoneal dialysis patients are there in CKD also. So it is not that it is used only for acute conditions.
Yes, sir.
Earlier, it was indicated as an acute therapy when hemodialysis was immediately not available. So that was
Yes,
the
sir.
older method of trying to replace the renal function.
Yes, sir.
But nowadays, patients who cannot tolerate hemodialysis, many of them are surviving with peritoneal ambulatory peritoneal dialysis,
Yes,
and it has got its own advantages. The patient need not come to hospital every second day and lie down for 3-4 hours. They can continue to work and go out, and the mobility is much more. And as long as they keep it without any infection, they can survive. I know a patient who was on CAPD for 8 years and then came for a transplant. So that much of stability in their hemodynamics is there. So that also has to be mentioned, how it works and how do you do that. What are the various types of PD also has to be answered when you complete your answer for RRT.
Yes, sir.
That should not be forgotten.
Yes, sir.
So I'll just share my screen with you.